Good morning, friends. This is Dr. Sanjeev Gulati. I'm Chairman Nephrology and Kidney Transplant for Fortis Group of Hospitals, NCR. Uh, at the onset, I'd like to thank the scientific committee for inviting me to give this talk. At the same time, my sincere apologies for inability to come because of some pressing family circumstances. So, I'll be talking about anemia and chronic kidney disease, leveraging evidence based treatments for current practice. When I think of anemia of CKD, I am reminded of this quote by Alvin Toffler that the illiterate of the future are not those who can't read or write, but those who cannot learn, unlearn, and relearn. In that sense, many of us from my era have had to unlearn some of the past treatments of anemia, which involved just blood transfusions, anabolic steroids, and we moved on to erythropoietin, and now this is an exciting era where we have now newer agents, namely the PHI-HIF inhibitors. First of all, starting with an actual case that I've been managing over the past few years. This is a 24-year-old male weighing 63.9 kg. He's done his BTech, he's employed, and he plays cricket and does cycling. Also does an annual trek to Vaishno Devi, a Hindu shrine, which involves a 14-kilometer arduous trek. Now, why am I telling you this? Because he is a patient who had CKD at 2.5 years of age. But because of erythropoietin, we were able to maintain hemoglobin of 10.7 to 11.4 with the creatinine. His last creatinine was 4.5, so EGFR of 18. But you can see the quality of life thanks to erythropoietin. He can do everything which a person of his age would be doing. Now, overall, the CKD's reported prevalence is about 9.1%, ranging about 8.5 to 10%. And what is important is as the stages severity of CKD increases, the prevalence of anemia also increases. Although the earlier stages of CKD, we all know, are more common than the advanced stages, but the anemia was twice as prevalent in patients with CKD in the general population, 15.4 versus 7.6%, and prevalence of anemia was 8.4% in stage 1 to 53.4% in stage 5 CKD. In India, it is estimated that the CKD patients, percentage of CKD patients who are requiring erythropoietin are anywhere between 30 to 35%, which is about 3.5 lakhs, and these are the non-dialysis patients, and among dialysis patients, it is about 1.72 lakhs. Now, there are two major players in erythropoiesis. One is erythropoietin. We all know that. It acts on the burst-forming cells and the colony-forming unit erythroid cells. It transforms them into erythroplasts, reticulocytes, red blood cells. But as you see here, iron incorporation is very important for an optimal erythropoietin action, and therefore iron-restricted erythropoiesis results in red blood cells that are hypochromic and microcytic. Now, these are the key recommendations for the most recent anemia guidelines. The KDIGO says that once ESR should be given if the hemoglobin is less than 10. The KDOKI also showing similar guidelines and with targets of anywhere between 12 to 13 that have been recommended. And these are the iron recommendations for iron supplementation and iron monitoring. We all know that. Now, this is the management of CKD anemia as per the KDIGO guidelines. It's available in all standard textbooks now, also on the net. It's a busy slide, but first and foremost, what I want to say is that yes, you should evaluate all CKD patients for hemoglobin. At the same time, look at serum B12, folate, and iron studies, and then try and work downwards as to if there is iron deficiency. First, supplement iron either orally or intravenously, or their vitamin supplementation is required. And if everything is replete, then we can embark on the erythropoietin therapy. Now, these are the benefit of treatment options available for management of anemia and CKD. And when I started my training in nephrology, we were mainly dependent on blood transfusions. It did improve anemia related symptoms. It still remains an option when rapid correction is required, an option for patients with chronic anemia in whom ESA synthesis is ineffective or detrimental. Then came the oral iron, wide and easy widely used, easy to administer, relatively inexpensive, avoids frequent outpatient visits, and new formulations are available, which increase absorption. It was followed by the intravenous iron, which bypasses the need for GI absorption and is incorporated more rapidly than oral iron into red blood cells. We have fewer administrations required to reach the target hemoglobin. It may delay or avoid the need for ESA therapy, and it suggests that the benefits for IV iron outweigh the risks, and newer oral irons are very safe. The ESAs were heralded a sea change, a new era in the management of anemia, and we have new formulations that are coming in. ESA therapy corrects anemia in CKD, shows clinical benefits, and reduces the need for blood transfusions. Blood transfusions have their disadvantages in terms of sensitization, especially for patients who are planned for kidney transplant. So they are best avoided nowadays. We know oral iron has a lot of side effects and which interferes with compliance. Intravenous iron now can be used. The newer irons are very safe, but yes, they do require staff and facilities for monitoring, but very minimal side effects. ESAs, are expensive. They're the largest drug cost for CKD or end-stage renal failure. 15% of these patients may not respond. And the KDIGO recommends great caution or avoidance of ESA in patients who have stroke, history, active malignancy, or there is history of malignancy also. So let's see what are the unmet needs with current therapy and the need for shift to newer therapy. ESAs, there is a progressive reduction in response or hyporesponsiveness, and we know that studies have shown, notably the CHOIR study, increased risk of adverse cardiovascular events, hypertension, stroke, thrombotic events, MI, heart failure-related hospitalization, all-cause mortality, cancer progression, diabetic retinopathy, and pure red cell aplasia. We all know that occasionally we see these patients. Intravenous iron, there is risk for bacterial overgrowth, GI side effects, hypersensitivity, and risk of infections, mortality, cardiovascular risk. So there are several challenges of the anemia management, namely inflammation, diabetes, cancer, hospitalized patients, patients who receive a kidney transplant. These are very, very challenging scenarios. A very important aspect that we have realized over the past few years is that there is reduced responsiveness to ESA in states of inflammation, which is erythropoietin resistance. About 5 to 10% of these patients with CKD will develop hyperresponsiveness, which is defined as a greater need for the requirement of ESA more than 300 international units per kg or 1.5 microns per kg of darbepoetin. And this hyporesponsiveness has been shown to contribute significantly to mortality, morbidity, healthcare economic burden in CKD, and it poses a diagnostic and management challenge. And the commonest cause of ESA resistance is either non-compliance, absolute or functional iron deficiency, followed by inflammation. So this is ESA resistance. We work down. If there is iron deficiency, you would supplement iron. If there is no iron deficiency, you look at all these causes. And among these, non-compliance, absolute or functional iron deficiency, and inflammation are probably the most important. So what is the burden of ESA responsiveness? These are the differences between ESA hyporesponsive patients. About 12,361 were studied in this study compared to normoresponsive patients. And as you can see, the IV iron use was significantly higher here. Similarly, the ESA was significantly higher, the PTH was higher, hemoglobin was lower, ferritin as well as transferrin saturations was significantly higher in the hyporesponsiveness group. And compared to normoresponsive patients, ESA hyperresponsive patients face the following challenges: significant higher responsiveness of IV iron and ESA, achieve lower hemoglobin, and worse iron metabolism as reflected by higher ferritin and lower transferrin saturation. Now, there is now newer understanding of CKD anemia, namely the important role of hepcidin. So which is released by the liver, especially in states of inflammation. Now, hepcidin acts on the kidney and normally stimulates erythropoietin production, but in stages of uremia, there is reduced erythropoietin production, reduced renal clearance. But hepcidin has a very important role acting on the GI system, and it prevents the absorption of iron from the GI system, from the duodenum. It also prevents the release of macrophages, iron from the macrophages, so thereby causing a state of functional iron deficiency. And thereby, so once you do not have enough readily available iron, the anemia is worsened. Now, inflammation plays an overriding role, as we are increasingly realizing in anemia and EPO resistance and chronic kidney disease. There are several cytokines which are released, which affect the liver, which increases the hepcidin release and causes iron deficiency. There are others which affect on the kidney, reduced EPO production. There are these cytokines which act on the bone marrow and decrease the erythropoietin blast forming units and again contribute to anemia. There is oxidative stress, mononucleophagocyte increase, which acts on the blood vessel. It's a shortened RBC survival, contributing to anemia, erythropoietin resistance. And this is a study which was published in Kidney Medicine 2020 as to how does ESA responsiveness affect clinical and economic outcome. A US RDS cohort of 834,000 patients was looked at on 6 months of continuous ESA use. It was found that ESA hyporesponders required nearly 4 times higher ESA dose and 5 times ERI resistance. The baseline characters, they were more often younger, females, had hyperparathyroidism and higher Charleston comorbidity score. There was a significantly higher risk of cardiovascular event hospitalization in the hyporesponders and higher healthcare resource utilization rates also. So the study concluded that ESA hyporesponsiveness in dialysis patients is associated with higher mortality, higher cardiovascular hospitalization rates, and healthcare costs. So something we need to keep in mind and manage. So management of anemia of CKD in patients with inflammation, you need to consider both the systemic inflammation as well as the exacerbation of anemia in CKD. And inflammation is indicated when the serum ferritin levels exceed 500. It is accompanied by a decrease in the hemoglobin and transferrin saturation. For maintenance of hemoglobin levels, higher doses of IV iron or ESA are required, and they in fact contribute themselves to increased hepcidin production, leading to a vicious cycle. So this is a slide talking about the treatment of anemia and difficult to manage patients with chronic kidney disease, which are anemia of inflammation, type 2 diabetes, cancer, hospitalization, kidney transplant patients. The inflammation causes reduced hemoglobin levels, and the clinical trials of HIF-PHI inhibitors in patients with non-dialysis patients and dialysis-dependent CKD patients have shown that they have increased hemoglobin levels, increased EPO levels, and may improve iron utilization regardless of hospitalization. So the study concluded that management of CKD is challenging in these patients, but there are new treatment options, namely HIF-PHI inhibitors, which may improve outcomes. Risks associated with ESAs, certainly to be kept in mind. Most common side effect is hypertension, and renal anemia is a factor predisposing to increased blood pressure due to increased sympathetic activity and impaired nitric oxide availability, and there is an increased risk of thrombotic events too. So the risks are pure red cell aplasia, accelerated tumor growth. Higher doses of EPO can stimulate endothelial and vascular smooth vessel cell proliferation, promote angiogenesis, and the anti-apoptotic pleiotropic effect of EPO can contribute to tumor disease progression. So when we are talking of a patient of anemia, we need to look at, for optimal iron and anemia management, look at iron, look at ESAs, but also look at inflammatory states, because it is here that there are newer agents which are available at our therapeutic armamentarium. And this is the journey of CKD anemia. You had prior to 1950s, just management of blood transfusions, then IV iron dextron, high incidence of side effects. In 1989, EPO was approved. Then darbepoetin came in. Then the iron sucrose came in. Then we have the newer irons, namely peroxycarboxymaltose, iron isomaltoside between 2007 and 13. Then the 2012 HIF-PHI inhibitors were marketed. Now we currently have 4 HIF-PHI inhibitors: the varladustat, molidustat, anordustat, and daprodustat. And then decidustat was the most recent one, which was approved in 2022. This is the DREAM-D study looking at the decidustat for the treatment of anemia in CKD patients not on dialysis. And It was a phase 3 multi-center open label study. I happened to be a part of this trial. So what we did was we enrolled patients who were between 18 to 80 years, between stage 3 to stage 5 patients who were not on dialysis, hemoglobins anywhere between 7 to 10. The desidustat arm received 100 milligram 3 times a week for about 6 months. The target hemoglobin range was 10 to 12. This is the primary efficacy. We enrolled 588 patients, 261 in the desidustat arm, 268 were given darbepoetin alpha, and what we saw was the desidustat was non-inferior compared to darbepoetin in the treatment of anemia and CKD patients who were not on dialysis. So safety was comparable to darbepoetin, and this is the treatment-related adverse events, which was similar in the two arms, and side effects again were not related to the investigational product. This is the ND study looking at anemia parameters. As you can see, this is the mean hemoglobin, this is the ferritin, this is the serum iron, and this is the transferrin saturation. So there was improvement in the hemoglobin, serum ferritin, transferrin, serum iron, and it was comparable to the darbepoetin arm. As you can see, this is the blue is the darbepoetin arm, red is the desidustat arm, and the transferrin saturations were actually significantly lower in the desidustat arm as compared to the darbepoetin arm. This is the DREAM-D study, and again, I was a part of the DREAM-D study where we looked at the HIF as a normal transcription factor which plays a central role in physiological response to anemia, and desidustat being an HIF-PHI inhibitor has been proven to be effective in increasing hemoglobin levels in anemia due to CKD. So we recruited 184 patients in the desidustat arm, 189 patients in the erythropoietin arm, and these are the secondary endpoints that we looked at. To sum up, desidustat was found to be non-inferior compared to erythropoietin in the treatment of anemia in patients with CKD who were on dialysis, and the safety, as you can see, the side effect profile was similar: 8.16% in the desidustat arm, 10.7% in the epoid and none of these were related to the investigational product. And this is again the DREAM-D study looking at the anemia parameters, and the effect of desidustat increasing the hemoglobin levels was compared to epoprotein alpha, and similar effects were observed in serum iron, transferrin, and serum ferritin. Adverse events again with desidus therapy, both the trials did not show any significant adverse events compared to erythropoietin. These are looking at the cardiovascular events, which are comparable between the darbo as well as the oral desidustat arm, both in the DREAM-D study as non-dialysis as well as the dialysis study. Now, there are certain other benefits of clinical HIF-PHI inhibitors, and one advantage is that it is an oral route. It increases or maintains hemoglobin effectively. It increases endogenous EPO production in the physiological range. It regulates hepcidin, which I showed you is a marker of inflammation, and it increases iron absorption by inhibiting hepcidin, and it is not influenced by inflammation, unlike ESA. The inhibition of HIF-PHD is reversible. It is transient. There is no risk of hypertension, and there are also pleiotropic effects like lowering of cholesterol levels, avoiding of high EPO levels, and avoidance of side effects associated with IV iron administration, which is reduced. Now, there are certain concerns that remain, obviously. First of all, till date, we don't have long-term safety data, and you should be cautious in using these patients who have malignancy, who have diabetic retinopathy, liver dysfunction, hyperkalemia. I think potassium should be monitored, but this is inconclusive, and this is similar to erythropoietin. Hypertension, again, similar to erythropoietin. Pulmonary hypertension, heart failure, I think so far safety data is not available. Thrombotic events, vascular calcification remain a concern. There is concern regarding cyst growth, so one should avoid this in patients with polycystic kidney disease. And seizure disorder clinical studies have not shown any signals that have related to PHI-HIF inhibitors. These are the hepcidin levels in the desidustat arm. So as you can see, at week 12 and week 24, there was in the darbepoetin arm, this is the this is the hepcidin level. This is in the desidustat arm, and there was actually an increase in the hepcidin levels in the darbepoetin arm. There was a significant reduction in the desidustat arm. Again, it has been shown that the use in animals like mice model actually attenuates autoimmune hemolytic anemia. The PHI desidustat increased hemoglobin in autoimmune anemia. It increased the RBC lifespan, decreased the antibody deposition on RBC, and desidustat also increased the erythropoid maturation in the bone marrow, and it also reduces iron in tissue and serum and suppressive oxidative stress and serum LDH. These are animal studies. We wait for human trials. Again, there is also very exciting evidence that desidustat protects against complement-mediated diseases, again in the animal models, and there is data to suggest that it may prevent the symptoms of acute nephritis, glomerulonephritis, membranous nephropathy in mice, and it is worth looking at trials in humans. These are the pleiotropic advantages of PHD inhibition on iron metabolism, glucose metabolism, lipid metabolism, protective factor for acute kidney injury. Again, renal fibrosis and CKD progression is controversial. There are some studies showing benefit. Inflammation is inhibited. Cancer development and progression, cardiovascular risk and atherosclerosis. The data is controversial, and we are looking for long-term safety benefit. Again, this is a case study which was published in Curious regarding the use of HIF-PHI inhibitor desidustat in a patient who had EPO-induced pure red cell aplasia, and it was used in this patient of desidustat led to a substantial increase in hemoglobin. Now, this is our own experience from Fortis regarding prospective single-center study on the efficacy and safety of desidustat in CKD-induced anemia. It has been presented at the forthcoming World Congress of Nephrology. The study period was January 23 to December 23, and we included patients who were iron replete. So a total 120 patients were enrolled. 64% were males, 35% were females. The mean age was 54.2 plus minus 18.4 years. And there was a significant rise in hemoglobin, as you can see, from 8.9 up to 10.1. And what we concluded was that desidustat is safe and effective oral therapy for the treatment of anemia in CKD patients, offering a viable alternative to traditional EPO injections. And it may also be particularly efficacious in patients who had ESA hyporesponsiveness. Now, coming to some of the guidelines towards the end, these are the Asian Pacific Society of Nephrology guidelines. Strategies when replacing ESA with the HIF-PHI inhibitors and the other way around. Physicians can consider HIF-PHI as alternatives to ESA in correcting and maintaining hemoglobin levels for renal anemia, both in dialysis-dependent and non-dialysis-dependent CKD patients, based on the new data concerning its efficacy and safety. And the guidelines also suggested that types of patients who should be treated with HIF-PHI rather than ESA would include anemia in CKD patients, should be controlled with ESAs or HIF-PHI after sufficient iron supplementation. If patients with good drug adherence desired oral treatment because of various reasons, such as frequency of hospital visits or invasive injections in cases of non-HG patients, then these patients could be offered HIF-PHI inhibitors. If the target hemoglobin cannot be achieved with the recommended dose of ESA due to ESA hyporesponsiveness, then these patients should be converted to HIF-PHI inhibitors. These are the European renal best practice guidelines. So they suggested consider use of HIF-PHI in non-dialysis CKD patients or PD patients where there is patient preference for oral route. They need to avoid injections. The challenges to start or receiving ESAs are there, like needle phobia, unable to self-administer ESAs, challenges to administering iron therapy or when increased iron availability is desired, if there is ESA hyporesponsiveness or intolerance. In hemodialysis patients, if there is a patient preference for oral treatment, home hemodialysis, hypersensitivity or unavailability of IV iron, ESA hyporesponsiveness or intolerance, chronic inflammatory states where like CRP is more than 3, but use with caution in vascular access with high incidence of thrombotic complications, retinal disorders, autoimmune diseases, history of cured malignancies, or kidney transplant patients. And certainly, they should be avoided in patients with the past history of cardiovascular or thrombotic event in the last 3 months, history of malignancy, last 5 years, all patients with polycystic kidney disease, untreated proliferative diabetic retinopathy, macular degeneration, retinal vein occlusion, idiopathic pulmonary arterial hypertension. Key points: make sure that your patients are iron replete, and we need to individualize the dose and maintain target of 10 to 12. Avoid rapid rises in hemoglobin defined as more than 2 grams over 4 weeks. And monitor hemoglobin levels at least monthly until the target of 10 to 12 is achieved and stabilized, and monitor potassium and liver function tests. These are the potential advantages of the HIF-PHI inhibitors compared to ESA in different CKD populations. In non-dialysis CKD, there is the convenience of oral administration, needle phobia, as I mentioned, ESA hyperresponsiveness and intolerance, chronic inflammatory states, hyperresponsiveness or unavailability of iron therapy, exposure to lower circulating levels of EPO, clinical trial on efficacy and data. Efficacy and safety data is available now. Hemodialysis patients, obviously, if those patients are on home hemodialysis, we could offer this kind of therapy. Peritoneal dialysis, all these advantages remain. And kidney transplant patients, again, with anemia, but we lack clinical trial data on safety and efficacy. Currently, trials are going on, and I hope in time to come we'll have clearance for this. To sum up, there are several new erythropoiesis stimulating agents that will potentially improve the management of anemia in the near future, and we are living in an exciting era. The new agents administered less frequently with better stabilization of hemoglobin concentration. There are also promising attempts to overcome the parenteral method of drug administration. There is a real chance that the new compounds will offer much more cost-effective than the currently effective erythropoietins, and the PAC will certainly improve the management of anemia and the quality of life, and hopefully also the survival of patients with CKD. And they are a unique advantage in tropical countries like ours and yours, where they do not need to maintain the cold chain, the HIF-PHI inhibitors. They can be safely stored and easily used. So that's another advantage in our setting.
CKD-MBD is a complex topic, and it's a vast topic. I may cover something, I may omit something. And I remember a quote just by Dr. Jha that whatever we practice is 50% may be right and 50% may be wrong, and we don't know which side it is. And it is very true of CKD-MBD. So coming to my topic, the CKD-MBD is a now term which is broadly describe abnormality in the mineral metabolism, skeletal health, and soft tissue calcification. These are all part of the CKD-MBD. And we should little about the pathophysiology. You can see the initial drive of the bone abnormality and the calcification in patient with CKD is increase in phosphorus. As soon as the GFR started going low, less than 70, phosphorus start increasing, and as a result of that, there is an increase in FGF23, decrease in clotho, and simultaneously there's a decrease in calcium because of decrease in the mass of the kidney, and which all increases the PTH, and which lead to the various abnormality. And this all tetrad of increased phosphorus, increased FGF23, increased PTH, and decreased 125 hydroxy vitamin D lead to various complications like metabolic bone disease, cardiomyopathy, and vascular calcification, which is hallmark of CKD-MBD. And this lead to further increase in the cardiovascular disease, which that one of the, this is the most important, most common cause of mortality in patient with CKD, increased fracture risk, and of course, increase in mortality in these patients. There is a classification of the renal bone disease. This is called renal osteodystrophy, which is new classification. This is called the TMB classification based on the bone turnover, mineralization, and volume in patient with CKD. And based on that, there are various classes like osteomalacia. So there's a decrease in the mineralization or turnover, but the bone mass may be intact or may be low adynamic bone disease where the turnover is low, mineralization is adequate, and mass may plus minus. Then osteoarthritis fibrosa where mineralization is normal, turnover increases, and the bone mass may go on down. And there are in between there are mixed osteodystrophy and mild hyperparathyroid bone disease. But there is another thing which also occur in CKD and which is not classified is the osteoporosis. You know the osteoporosis defined by WHO, the T-score less than 2.5, and there's a defect in bone strength, both bone density and bone quality, and which is also responsible for increased fracture risk in general population, postmenopausal women, and in patient with CKD. So this is also an aspect of the CKD mineral bone disease, which is separate from the normal renal dystrophy. And osteoporosis is highly prevalent in CKD. The incidence is more than 2 times in the patient with GFR less than 60 as compared to those who have GFR more than 60. And you see more than 80%. So the osteoporosis is quite prevalent in the patient with CKD, and more than 80% of women, more than 50% of men, more than 60 years, they have GFR less than 35 ml. So this is very important, and the fracture incidence is 4 times as high as compared to the general population, and outcomes are worse in patients with CKD, obviously because of the complex architecture, complex mechanism which are going on in non-dialysis as well as in dialysis patient. Obviously everything increases much more in patients who are dialysis dependent. So the test which we do to see whether what is the quality of the bones and the quantity of the bone. So DEXA is the scan which is useful for the evaluating fracture risk in the general population, fails to adequately discriminate the bone quality, and bone quality comprise of many things like architecture of the bone, turnover, trabecular bone, mineralization, bone matrix, and this is not measured by the DEXA scan because it is a 2-dimensional test. But in CKD, half of the osteoporotic fracture can occur when the T score is more than 2.5. But the recent guideline which has been published by KDIGO in 2017 showed that CKD-MBD in patient, you should do a DEXA scan in the patient who also have a CKD. Previously in the old guideline that has not been advised. Why? This is based on some of the studies which have been conducted after 2012, and it has shown that whether it is a patient with CKD or non-CKD, the risk of the fracture increases significantly when you have a DEXA scan, and there is not much difference between CKD and non-CKD, although it is not the best test, but that can be used in patient with CKD. How can we enhance the sensitivity of the screening of bone quality? There are another tool which has been more and more utilized nowadays, which is called the fracture risk assessment tool of FractScore. This is a computer-based algorithm that calculates the probability of the major osteoporotic fracture and probability of hip fracture over the next 10 years. You have to put the various values in a computer-based algorithm, and you will find, and then you can see again that the patient with CKD or without CKD, you can use this score, FractScore, to know the risk of the developing fracture in patient with CKD. Coming to the other test, usual tests we do, we know that calcium, phosphorus, IPTH, and some of the bone biomarkers. And then you can also do, to know the quality of the bone, you can do the peripheral quantitative CT scan, which tells about the trabecular bones also, which is also an important parameters. But then again, repeatedly doing its ionizing radiation, and this is a costly test. MRI can also be used. Obviously, the bone biopsy remains the gold standard, but then doing a bone biopsy has again its limitations because of the cost, because of the interpretation, and because of the invasiveness of the procedure. So it's not usually recommended unless you can't do without it. There are certain bone biomarkers which can be used, but again, doing these bone biomarkers routinely is not possible. PINP is a marker of the bone formation as well as bone alkaline phosphatase, and then there are marker of bone absorption, intact PTH, TRAP, and collagen CTX. These are some of the markers. So based on the various studies, this is a recent paper which has come out, has shown that you can use some of these biomarkers like PINP, diagnostic cut of more than 120, good predictor of the high bone turnover, TRCP1 less than 3.4, good predictor of the low bone turnover, and the combination of these markers can be used to know whether the patient, without doing a bone biopsy, a reasonable accuracy to find out the type of the bone disease. Coming to the management of CKD-MBD, so there are, as I mentioned previously, there are two problems in patient with CKD. One is the osteoporosis and another is the CKD-MBD, which is the usual TMB classification system. And based on the whether patient osteoporosis, you would use, apart from the lifestyle modification, which is a very important first step for the managing osteoporosis, vitamin D supplementation, dietary calcium, and then there are two main therapies, anti-reabsorptive and anabolic therapy. And the second one is the CKD-MBD, and depending on the PTH level, you can suppress or increase the PTH and give the treatment accordingly. So very important initial step in the management of the CKD-MBD is you should supplement vitamin D, normal 25-hydroxy vitamin D to all patients with CKD, and keep a level about 30 to 40 nanogram per ml, and that will help to reduce the PTH in patient with early stage CKD or 3 or 4. And then there are various therapy to reduce PTH, reduce phosphorus, maintain calcium. So dietary phosphate limitation is a very important part of the management of CKD-MBD. One should avoid food which are very high in phosphorus, and hyperphosphatemia should be controlled. Then there are various drugs which can be used. You can use phosphate binders, which are calcium containing or non-calcium containing. You can use, if there is severe hyperparathyroidism, you can use calcium mimetics or vitamin D receptor agonist. Phosphate binder, what is the evidence? The initial meta-analysis which was conducted some time back, they shown there was no difference in the calcium containing or non-calcium containing binders in terms of mortality. But later on, this guideline in 2016 and another guidelines, meta-analysis later on showed there's a high mortality with the calcium-based phosphate binders. So KDIGO 2017 suggests that restricting the dose of the calcium-based phosphate binder in patient with CKD, but then like in our practice, we see sometimes patient coming in the later stages, especially the younger patient, they have high incidence of hypocalcemia and high PTH, and some of these patients and many of these patients need to be given calcium containing phosphate binder, which is very important. Obviously, you have to see those patients who are diabetics, patients who have received calcium supplementation or in dialysis, especially PD. These patients should be avoided with the calcium containing phosphate binder. The previous guidelines suggested that phosphorus and calcium should be kept in the normal range, but then KDIGO 2017 suggests that all variables should be considered rather than a specific value. So it's a dynamic thing. It's not a static thing based on the changes in the calcium, phosphorus, PTH level. Important thing is one should avoid hypercalcemia and restrict the use of the calcium containing binders and vitamin D antagonists. And there is no word about the calcium phosphorus products because the hypercalcification is quite common in the patient with CKD. Secondary hyperparathyroidism. So patient, you need to control the secondary hyperparathyroidism patient with CKD, and one should assess all the factors like hypercalcemia, hypocalcemia, hyperphosphatemia, vitamin D deficiency. In the early stages, you can use 25-hydroxy vitamin D, and you can use combination of any of these therapies depending on the calcium level, phosphorus levels. And parathyroidectomy is only indicated for patients of severe hyperparathyroidism who fail to respond to medical or pharmacological therapy. The usual cutoff is more than 1000, but then depending on the response to therapy, patient, you can decide for the parathyroidectomy of this patient. Few lines about the management of osteoporosis. So there are various agents which are used for the treatment of osteoporosis in patients with CKD, vitamin D receptor, but this shows that there are very few RCT. There's only RCT available for the Cinacalcet, and then all the other treatment is based on the post-hoc analysis. Some of the agents like Cinacalcet, calcium mimetic, they can cause hypocalcemia and low bone turnover disease. One should be careful. And then there are two treatment, mainly the anti-reabsorptive therapy like bisphosphonates or denosumab, and the anabolic agent, which is teriparatide and evaloparatide, which can be used in the patient who have low turnover bone disease. So one has to choose carefully which type of the disease and then to go for the treatment of these patients. So bisphosphonates are used for quite some time. They induce osteoclast apoptosis, but they are retained in the skeleton for many years. They are also excreted by kidney. So previous recommendation was that one should not use these agents when the GFR is less than 30, but then there is some new evidence that up to 15 ml of GFR you can use these agents safely. But whether should we really use these agents? Because if you see, those recent studies have shown that they can actually harm. And even there is some evidence that CKD progression can occur when you use bisphosphonates. So one should really careful think about using these agents in patients with CKD. What is the new denosumab, which we know this is a potent anti-reabsorptive agent. It is a monoclonal antibody against the receptor activator of NFKB ligand and inhibit the osteoclast proliferation and development. It is not cleared by kidneys and no risk of over-suppressing bone over the long-term use. So this is the freedom trial, which is the most important trial done to know the effect of denosumab. This was done in postmenopausal women. Most of the patients, they had normal renal function. Very few patients with the CKD3 and beyond, and CKD4 was only 76 patients. But it has shown that there was significant improvement in bone density over a period of time with use of denosumab, and that have shown 68% lower odds of developing vertebral fracture in these patients. Long-term safety of the denosumab is also now being published. 10 years of the treatment. The majority of the individuals in the treatment arm shifted within grade 0, and there was less hypocalcemia, but which may be true of the general population. But in the patient with CKD, there are high chances of the hypocalcemia. So one should be very careful and supplement with calcium and vitamin D, especially those patients who have normal calcium or the low calcium level before starting this treatment, and then continuously monitor the calcium levels in these patients. Although the numbers are less, but it has shown that fracture risk also reduces in patients with CKD stage 3 and 4. There's not much data, but whatever data is there, you can use this agent safely in patients with CKD stage 3 and 4. And there is some studies in the patients on dialysis also, and it has shown there is a consistent improvement in the BMD, cortical thickness, and no change in the vessel status, and risk of the mild to severe hypocalcemia, which increases with CKD severity. Discontinuation is again a controversial thing. Most of the patients, they again started following BMD if you discontinue these agents. So don't know how long you have to use, but you have to use it in a long-term basis. The other treatment which can be used in osteoporosis in CKD patient are anabolic agent. These are typically used in low turnover bone disease. They should not be used in high bone turnover bone disease because it will increase the cortical losses. So this is a study which has been conducted in postmenopausal women, and they are given teriparatide at the 20 to 40 microgram per day, and this increases the bone formation marker and the BMD. But the problem with this agent is there's an increased incidence of hypercalcemia and hyperuricemia. So these things should be monitored once you are giving teriparatide. It has to be given daily, and it has improved the osteoporosis and the BMD in these patients. There is some experience of using this agent in patients on dialysis. The only experience of few patients, but it has been found to be effective on those patients also. Abaloparatide is a newer agent which has been used for the treatment for the osteoporosis, is approved by FDA, and there is 50% lower risk of hypercalcemia than teriparatide, but there is no data in CKD and MBD. So this is a rough algorithm what you should do once you have a patient with CKD-MBD, if the GFR is less than 60 and clinical risk factor. So very important is the lifestyle modification, that you should give vitamin D, and then you should weight bearing exercise, adequate nutrition, fall prevention strategy, and if one should do the DEXA scan 1 to 2 years, if the T score is less than 2.5 plus minus fracture, and then or T score is more than 2.5, and in any case whether it's a fracture or not fracture, you should assess bone turnover. And there is a controversy that because the bone turnover marker are not easily available, one can use bone alkaline phosphatase or some other marker. If there is a high turnover or normal turnover bone disease, you can give anti-reabsorptive agent. If there's a low turnover bone disease, you need to give anabolic agent. And in case of doubt, one should go for bone biopsy, but practically it is very difficult to go for the bone biopsy because of multiple reasons. With that, I conclude it. And
all set now. So I'll start with this slide, and I think that I don't need to say who that is. This is the mummy of Tutankhamun. He is one of the pharaoh who became more popular after he was dead. He was a child king, died in his early youth, and that is his mummy. And he became popular because we found the whole sarcophagus of his dead body, and we learned so much about Egyptology because of him. I'm interested not in his dead body, I'm interested in mummification process. It was clear then that there was a two-tier system for mummification process during pharaonic time. The royals used to get a different type of mummification, and the ordinary people would get a different type of mummification. The difference was very small, that in the mummification of royalties, they used to keep kidneys and heart in the body. But for the ordinary mug like you and me, all the organs were kept, and the mummification process happened. The reason is very interesting, that at that time, the Egyptologists thought that when they go to the next life, they needed heart, which they thought was the seat of the soul, and they needed 2 kidneys to keep that soul purified. So if I was to reinterpret that several thousand years ago, those Egyptologists were well ahead of the time, and they knew then that there are only 2 good organs in the body, the right and the left kidney. And you need those 2 kidneys to keep the heart healthy. So that's what I'm going to talk to you about today, that you need to preserve the kidneys to protect the heart. It took thousands of years now, and only last year, ASN and American Heart Association have joined together and put out a new acronym, which in years will replace CKD. It will be called CKM. This will be the new acronym which is being proposed, which stands for Cardiac Kidney Metabolic Disorder. And why that is the case? Because we are so fortunate that there have been so many drugs which have come, which were developed for a metabolic disorder like diabetes, which has turned out to be super hit for protecting heart as well as the kidney. And there are so many, you can see, there are so many pillars which have now come about. Just to take you 4 decades ago, when I started my career as a medic, there were no pillars. These pillars did not exist. Instead, we had few bricks. And the few bricks were controlled blood pressure and low protein diet. We were obsessed with that. Now we have replaced those bricks with these pillars, and I'll go very briefly into those, because I'm not going to go and show you and bombard you with the clinical data, because I don't think so. You can open any medical journal when these agents are not being mentioned. So let's start with how to look after a CKD patient, how I look after the patient. So I always call the patient myself, and the room where the reception area and my clinic, there are around about 50 steps. So I go out and call the patient and bring him into my room, or her. And during that walk, I assess her frailty. This I've done it all my life, that how frail this patient is. Then before I've called the patient, I've already done the assessment that what is the kidney failure risk of that patient. I do it old-fashioned way. I look at the slope of the GFR as well as proteinuria. Now for the youngsters, there are so many equations. You can just put the numbers and you will get the 10-year, 15-year, 20-year kidney survival of that patient. So you can choose anything you want, and you should do that regularly every 6 months so that you realize that can I do better and improve the kidney survival. I have always done atherosclerotic cardiovascular risk assessment in all my patients. And the new equation which has now been proposed is called PREVENT equation. I would like you to do that because it's the first equation which puts proteinuria and eGFR in the equation to give you 10 years cardiovascular ischemic risk. I can tell you, if you don't want to do that, that anyone who has got UPCR of more than 50 should be on statins. That is the golden rule. They should be on statins. If they can't tolerate it, or there is any doubt, there is no reason not to take cholesterol into consideration. We have got now 3 very good drugs available. We can give bempedoic acid instead of statin. We can add ezetimibe and lower the dose of statins. And more importantly, PCSK9, when it becomes affordable, you guys will be able to use it as well in this country. So that you need to protect it when patient has got proteinuria. Let's go into these pillars. They are being talked about, but they are already out of date. So let me go through them. These we have known about, that spironolactone and eplerenone. We have used it. The first heart failure trial was positive for spironolactone, which was called RAL study, and many cardiologists have been using it. We have been shy in using them with CKD that it causes hyperkalemia. Now we have got so-called non-steroidal, more expensive Fineron, which has been used in CKD, mainly diabetes, but CKD trial is ongoing and the results are very good, that it protects the heart as well as the kidney. What about GLP-1? That is already out of date. Now we have got GLP-1 and GIP-1 agonists. And there is a third, another group of drugs which are being developed called 3G agonists, which will be glucagon receptor agonists. And in my opinion, that will be the gold standard which we'll be using in a few years' time. Will it be affordable for Sri Lanka? I can't tell, because you will be the person who will tell me that how expensive it is in single form, how expensive it will be if you develop a 3G agonist. SGLT2 inhibitors, you have heard all about it. I don't have to talk about it. There's a ton of data. But again, it is going to be out of date. It is going to be SGLT2 and 1 inhibitors, which are being developed. Already sotagliflozin has shown very promising results, and would be able to be used even in end-stage renal failure because it inhibits the absorption of glucose from the gut. So my prediction is that SGLT2 will be replaced with a drug which will be inhibiting both SGLT2 and SGLT1. Now, how I use it? Now I had never had. I was not used to so many choices. The problem is this, that all the studies which I've shown were short-term. They were placebo-controlled trials. No proper comparator was compared with this trial. So for example, I give you Fineron, which is the drug, very expensive, should have been tried against spironolactone. No, that was placebo-controlled. Inclusion-exclusion criteria were very tight. One of my colleagues who does clinical trial, when we were recruiting it, he told me for every 5 patients he screened, he could only recruit 1 patient. So the 4 patients missed the cut. Adherence, obviously, in clinical trial is 90%. What happens after the clinical trials? Nobody knows. We need to be careful when you're using this GLP as well as SGLT2 that you get significant muscle mass loss. So some of the creatinine benefit which you see could be because the muscle mass is lost. And in fact, there is now a move that we will have to reset our protein intake for CKD patients when they're on these, because they do get sarcopenia. Again, creatinine is assessed by a very cheap method in the urine called Jaffa technique, and high glucose interferes with that. We need to always look at fragility index, and that is in fact very simple. You just put it as an equation, you put the numbers of it tells you what to put, and it will give you how many number of patients which in the positive arm have to lose that positivity for that study to become negative. So if you have only got 8 patients to move from one to another arm and it becomes negative, obviously it's a very fragile study. So we need to gather this data, use this and find way of getting real-time data. And I think Vivek and Avanja has already gone through this, and this is pragmatic randomized control trial. That will generate whether these very, very expensive drugs, which have been launched by the drug companies, have shown efficacy in the randomized control, placebo-controlled trial. Will they show effectiveness in the real world? And these are the pragmatic studies. I just want to bring to your attention 2 studies which were published in 2024, one in New England Journal of Medicine and one in JAMA. And I would like to take you through very briefly that these were electronic data-based studies. This is what Vivek was talking about. You can just have the data and then randomize them. In both these studies, thousands of patients were included. In one study, they looked for hospitalization rate. They were CKD patient, and in another, they looked at renal outcomes. Both studies are published, and you can read them, but I'll just give you the top line. In one intervention group, a nephrologist, a nurse, and a pharmacist contacted the patients, identified in the primary care setting, and went through the whole guidelines, all the education, and then put them on guideline-driven therapy, latest guideline therapy. The other group was left to primary care physicians to manage the way they want. As a result, in both these studies, 95% of the patient achieved guideline-driven therapy. In both these studies. And in the primary care group, which was not contacted by these specialists, the guideline-driven therapy was only 40%. Now, guideline-driven therapy, which I'm talking about, should have made difference, isn't it? After a year, there was no difference in any endpoint you looked at it. Hospitalization rate, rate of progression, hypertension control. These are 2 pragmatic trials which have been published in 2024. Why? Because patients don't take the tablets. In clinical trials, somebody is breathing down their neck every week, every 2 weeks. Here, you told them and you expect them to take it. And possibly they did not take the tablet despite doing ours. So I don't know how we are going to resolve that if you have got gold, it doesn't always glitter. And it's not glittering when we have taken them to our patient. But there is something which is gold, but it's not glittering. Okay? And these are the simple tools which we have got. We like to give the drug. Patient wants to have a drug. We don't have the patience to talk to the patient and go over these things. Healthy diet, salt-restricted diet, physical activity, stopping smoking, healthy sleep, healthy weight, blood cholesterol, blood glucose, blood pressure. And also social isolation. One of my PhD students is doing this. And I was amazed to see how much social isolation exists, even of Asian origin people in my area. They're suffering from social isolation. So we need to take a lot of interest in this, and they work. We have shown that if you were to restrict the salt in a South Asian population, in my clinical practice, it lowered the blood pressure equivalent to 3-agent antihypertensive. So it does work, but it takes time. It really takes time. If all the junior faculty sitting, if you were to tick all the boxes of all that 8 essential of life I told you, you will have 10 years of comorbidity survival. What I mean by that, and this is the data from United Kingdom, free NHS at source, no question asked when they come. I can do any test I want and I can give them any medication. I don't have to worry about whether they can afford it or not. Now, what is the state of health in our nation? The life expectancy in Britain at the moment is approaching 83, 84. The healthy lifespan of our senior citizen is only 60. 2 decades of their last life, 2 decades, they are ill. They are taking tablets. They are hospitalized visit. Do you want to create a society where your life expectancy will hit 90, but 30 years of last 30 years would be chronic illness? If you want to avoid that, you don't need tablets. You need healthy lifestyle. And for that, you will have to start from schools, from colleges. And we have not done that in the United Kingdom. One thing is for sure, there's one thing guaranteed. A person who was born, he's going to die. That is the certain thing. Nobody has lived forever. How long he's going to live or she's going to live is determined by what sort of a life that person chooses for him or herself. And the process by which it is determined is called biological age. The scientific word for biological aging is senescence. What is senescence? All our cells are dividing all the time. If they stop dividing and go into permanent cell arrest, they don't die, they just stay there. They are called senescent cells. As the biological age is speeding, your number of senescent cells in the body is increased. Those senescent cells are like old people. They can do nothing, but they become burden on the society, as what the health economists will tell you. These senescent cells in your body are making low-grade cytokines and stopping the function of normal people around them, or normal cells. That is biological aging. In research tool, we can measure all the biological aging of a person. And this is the data of one of my PhD student, that how can we say this biological aging equates to frailty? I use this very complex method of assessing biological aging, which is a measurement of the muscle heart. There's some objectivity to it. And if you look at it, our biological aging was much stronger predictor of how frail our patients are with CKD or dialysis as compared to chronological age. I can give you one example. I had a patient who was 40. His biological age came as 65. He was surprised to know that. But at the same time, I had an 80-year-old whose biological age was 55. So it goes both ways, depending on how you have lived your life. And it equates to frailty. And frailty is the best predictor of how you're going to do in terms of healthcare use and your survival. Just go quickly. I've been working with cardiologists to change the term called left ventricular hypertrophy. Left ventricular hypertrophy doesn't exist, at least in CKD, because we should call it myocardial thickening. I'm just going to show you the histological data, that this is the normal heart. This is LVH, what non-renal failure with hypertension will get. Same level of echo and finding, you get the LVH, but look at the LVH, which we call in CKD. Hardly any myocytes, it's all fibrosis. So we need to look at, if you do an echo on CKD patient, it says LVH. Remember, it may not be LVH. It could be a fibrotic cardiomyopathy. And this is also present in people with normal renal function. And if you were to take a histology and do a postmortem on somebody who is 90-year-old died with normal kidney function, this is what the histology of his heart will look like. So it is aging. Our CKD patients are prematurely aging. And one of the ways to look at it, or scientific ways, that autophagy, which is a mechanism of recycling all the organelles and proteins which our cells do, is it happening or not? And one of my PhD students, as you can see, saw 84 genes which are involved in autophagy. They were normal in uremic heart, but they were all abnormal. So autophagy is not happening in uremic animals, and I'm sure that is what is happening in the patients as well. So I would say, when you look at somebody's age, ask a question. Is he aging normally? Is he aging healthily? Or is aging unhealthily? Looking at the biological marker, and one of them for you for clinical tools, before those markers which I told you have become clinically used, look at the frailty score. Just take you to pharaonic time. The life expectancy in pharaonic time was, you can see, 25 years. So if you lived 26 years, you were lucky. And it remained so for 10,000 years. At the turn of last century, when you had industrial development, mass production, look at the life expectancy. It's exploded. So we are living longer. But today, you can see that the GDP of a country directly correlates with how long your nation would, your population expectation, life expectancy would be. Today, 21st century, there are some countries. Look at Sierra Leone, a country with the lowest life expectancy. This is 21st century. This is unequal distribution of health care. People in Sierra Leone, if you are unlucky and born there, your life expectancy will be less than 40. What is going on in Sri Lanka? This is going on in Sri Lanka now. Your GDP is increasing, even though you had some economic trouble, I am aware, but still your GDP is increasing, and you can see your life expectancy is increasing, and it has increased more than what it has done in the last 10,000 years. When you have life expectancy increase, you lose all the communicable diseases and you replace them by chronic diseases. This is what happened in UK. These peaks appeared when we lost communicable diseases, tooth decay, trauma, diabetes, heart failure, CKD, dementia, cancer. All these things are waiting for you. If you don't look after yourself, all these things will happen to your population. And if I'm wrong, I go to the pharaonic mummies, which were the normal monks like you and me. When we did a CT on them, you can see that they had atherosclerosis already when they lived into their mid-age. So they were lucky. They lived in mid-age, so they had atherosclerosis. It's not a modern disease. And now in NHS, we don't have dentists. And we have developed an interest, and we can show that dental caries is very common, first of all, in clinical, and we have developed an animal model to study the inflammation coming from periodontitis, and it will be published very soon. God, look at the carnage we have to do. Look at all the predictors. So 850 million CKD patients. Now we know there are 800 million diabetic, 2 billion smokers, 1 billion above the age of 60. Family history, 890 billion obese people, 620 million with ischemic heart disease, and 1.2 billion with hypertension. They all feed into this country. The country is the third most populous country in the world, which is called CKD. And to the healthcare cost of this country, just one country, healthcare cost will be $2 trillion. It's not sustainable. Coming to CKM, very worrying. 86% of the patients in United States only have got stage 1 CKM. So in order to counter this, you guys can do it, that you need to develop a faculty of lifestyle medicine. You need to have medical students learning about lifestyle medicine. We will have to develop tools so that we can give personalized therapy by multi-genomic signature. And a day will come, rather than doing expensive studies, what oncologists are now doing is called N=1. They take a biopsy, they do proteomics, transcriptome, metabolome, and then select the drug which will be suitable for that tumor. That day is coming. I don't know how long it will take, but one day will come when your computer and AI will tell you that this is the molecular signature of this condition. It is diabetic kidney disease, but the drug to use are these three, because they are the one which will attack these three abnormal pathways. At that, I'll